Hello, everyone. My name is Dr. Akinwande, also known as Dr. A, and I'm here to talk to you about prostate artery embolization and its utilization in the treatment of benign prostate hyperplasia. Prostate artery embolization is also called PAE. It's a safe, effective, and life-changing prostate treatment. I would love to share that with you if you can just stay tuned. And this is the only non-surgical treatment for benign prostate hyperplasia or BPH. So I would like to educate you. And obviously, if you have any questions, I'm going to be answering questions after the presentation. So if you have them, just enter them into the chat, or you can email us your questions. Okay. So the question is, we're gonna actually pose a lot of questions. So I'm gonna list a lot of questions here, and my goal is to answer all these questions. I feel like a lot of these are the more relevant questions, and so I am going to list a couple questions. And obviously, like I said, if you have additional questions, put it to the chat or add it to the chat, and I would be sure to answer it right after. Well, I will answer some of them. I can't answer all of them. So number one is, what is benign prostate hyperplasia? How do I do a prostate artery embolization procedure? Does the procedure hurt? We're going to compare prostate artery embolization versus TURP or other surgical options. There are different surgical options for benign prostate hyperplasia. So we're going to talk about do some comparisons and see if prostate artery embolization is the right one for you. Why urologists don't recommend PAE? We're going to have fun with that, and I would love to tackle that question, if you will. Does insurance cover the cost, or how do I pay for this? And we're going to talk about that. How does the procedure, or how long does the procedure take? How much downtime after PAE? Some people are concerned, obviously, about going back to work. How long do they have to take off from work? So these are some very important questions, and hopefully I can answer those questions, and maybe this procedure is the right one for you. So a little bit about me. I'm an interventional radiologist, a board certified interventional radiologist. The long and short of it is, I'm a procedurist that uses images to do procedures. We are the only ones board certified to do embolization procedures. An embolization procedure, prostate artery embolization, an embolization procedure is when you slow down or shut down the blood flow to something. And this is part of our fundamental training. So an embolization is not a unique concept that we just made up for this procedure. We've embolized all parts of the body. When people have internal bleeding, we stop bleeding by doing an embolization. It will be usually someone like myself that will be called upon in a trauma hospital to go find the bleed and stop the bleeding. So embolization is not unique. Now, the application of embolization for prostates is something that has come over the last couple years, and I do have a slide that tells you a little bit about the history of prostate artery embolization. So if you're not an interventional radiologist, you probably weren't trained to do this in your fellowship, and so it's important to understand that. We are procedurists that use images to do procedures. So I was fortunate to get trained at prestigious institutions such as the University of Pittsburgh and the Johns Hopkins Hospital. Here's a picture of myself and some colleagues, maybe going out to lunch, and we decided to take a picture right before lunch, I think. My first job, I was recruited as academic faculty at Washington University in St. Louis, which is Barnes-Jewish Hospital. We call it Big Barnes over here. It's a prestigious academic hospital in St. Louis. I was very proud of this accomplishment of being faculty here. I started my career doing clinical medicine as well as academic or research medicine. I had 20% protected time to do research, and I really enjoyed mentoring medical students, fellows, residents, teaching residents and fellows in this job. I had the ability to publish over 80 peer-reviewed abstracts and manuscripts. You can look this stuff up. You can type in my name and Google Scholar. You'll see all the abstracts and manuscripts I've published and presented across the world. And I really enjoyed my time there. But or actually, this is a picture of myself with one of my medical students, and who ended up publishing a paper with me. Here is one of my prior fellows that I trained that ended up going to University of Pennsylvania as faculty. I loved this, but I felt that I had a hard time reaching patients. I remember one time I went out I went out marketing, and I remember them kind of telling me, "Why are you marketing?" And because we're WashU, and people just show up to the hospital. I don't have to go and market to do outreach and tell the community what I did. I don't have to go to you know, health fairs and whatnot. We'll wash you. That's the way they kind of looked at things. And I felt like there were a lot of people having surgeries that didn't have to have surgery. There were a lot of options for people that are not surgical. But a lot of times when people get a problem, the first thing is surgery. If you had a back problem, you don't go to a spine surgeon, right? You go to a person that first of all, you go to physical therapy, and then you go to someone who can maybe give you some injections. You don't jump into surgery. So if you have an enlarged prostate, why do you need surgery right off the bat? There should be options for those patients. And so I started Mint in 2019 because of some of these issues. I felt like I wanted to really reach the community and give better access to what I did and the types of treatments that I had to offer. So here is kind of a nice picture of where we're located. This is St. Louis, if you guys have not figured it out already. And by the way, I know there are people from St. Louis that are listening to this as well, probably the majority of you, but I know from these webinars, I do get people from out of the country that are curious, and people from out of state that are curious. And so this is St. Louis. This is the famous St. Louis Arch. It's beautiful at night. And yeah, this is where we're located. If you haven't been to St. Louis, please be sure to visit. It's a really good, cool city. We have great food and great culture here. Here's my practice. You can see the front office, very inviting. We have music to hypnotize you there. I'm just kidding. But yeah, very, very inviting environment. Here's my procedure lab where we do all our procedures, state of the art, everything. I get the best of the best, and want people to feel cared for and feel listened to, and we want them to have great outcomes. And here's my staff. We have a diverse group of folks from all walks of life, and it's my pleasure to work with them. It's a beautiful team, and you will meet them if you ever check us out. So let's start from the beginning. Okay, so what is benign prostate hyperplasia? So if you can imagine, I'm going to use my mouse here so I can show you guys. So here's the bladder, and that's urine within the bladder. Your prostate gland is a kind of like a nut-shaped or a walnut-shaped organ that surrounds this tube that leads from the bladder into the penis. Okay, right here is kind of like a seminal vesicle, and this has this little tube that passes sperm into the urethra. So basically, your urethra is the place where urine passes and also sperm passes through. Your prostate gives a fluid that lubricates that sperm, and it surrounds this tube. And the problem with that prostate is that when it gets bigger, it can really compress on that tube, making it very difficult for urine to leave the bladder and go into the penis or out through the penis. So that's basically the mechanism of BPH. If you're a man and you live long enough, you will probably get an enlarged prostate at some point, because it's really, really triggered and stimulated by hormones, and we have a lot of them. That one is called testosterone. The main one is called testosterone, and also it's also very stimulated by blood flow. They tend to have very, very large blood supplies when it gets large and large and large, and that's why we can target the prostate artery when we do prostate artery embolization. Here is an MRI of the prostate gland. You can see kind of focus right there in the middle right there. You can see that's the enlarged prostate. And in this particular patient, there is a Foley in place. A Foley is a tube that they put through the urethra. That urethra, I talked to you about that tube that leads from the bladder into the penis. And that urethra or that tube helps drain the bladder. It helps drain the bladder of urine. So it helps pass the urine from the bladder down to the penis. So in this particular patient, he had a large prostate gland, and he was just not happy having a Foley. It was placed in the ER, and he goes for regular checks, regular changes from his urologist, but he doesn't want surgery. He's about 90 years old. He doesn't want surgery, but he also doesn't want a catheter. So obviously, he's a patient of mine. So again, there are different patients that really, for whatever reason, don't want major surgery. And could you blame them? No. So let's start with medical treatment for BPH. If a patient has BPH, we usually start with medical therapy. Usually there are two major groups of medical therapy. One is a group that relaxes the muscle in the prostate and the urethra, and we call that, that's your Flomax and Cialis. Flomax is the main one. Cialis can help some patients, especially some patients that have sexual dysfunction as well. It's not uncommon to have patients that have prostate problems also have sexual dysfunction. So Cialis may help them. Then the other group of medications are the medications that block hormones. Remember, I told you that hormones tend to cause the prostate to get larger. And if you can block kind of those hormones, you can potentially have the prostate shrink. And that's that other medication called finasteride. Now, if you're on this call or in this webinar, you probably are already on one or both of those medications, and maybe those medications are no longer working, which is not uncommon. Usually it would start working for some patients, and over time it might stop working, or some patients have side effects of these medications and maybe want something more definitive. They want a more definitive procedure. So the standard of care, or not the standard of care, the gold standard for the treatment of an enlarged prostate is a procedure called TURP, which is transurethral resection of the prostate. Okay. Now let's walk through the name transurethral. Transurethral is trans means going through. Urethral means that urethra that we're talking about, right? So we're going through the urethra. So we're going through the urethra to resect the prostate. Okay. That's the device. We're going through the penis to resect the prostate. Now, you can already see the problem with it. Obviously, it's not the funnest thing to go through the penis to do a procedure, right? But also the fact that you're resecting the prostate through that tube we talked about, that urethra, which is very unnatural, right? If you're going through a tube that was designed to be a tube, and then you're through that tube, and then you're just carving portions of that prostate, the tube is no longer a tube anymore. And so you can start to have problems with that. Here's another schematic picture that kind of shows you what's going on. You're going through that urethra, you're here at this narrowing, and then you take this device and you start basically carving out areas of that prostate. So you can see kind of the anatomy of that prostate is no longer ideal. Look at that. That's that tube, that urethra, and you can see kind of this deformity. Now, TURPs do work. That's why they are procedures. But obviously, whenever you have a procedure like this, there's always, what's the downside? Downside is potentially the side effects. One of the side effects is retrograde ejaculation, where your ejaculate after sex, the ejaculate does not come out. It goes in reverse, right? You can also have urinary symptoms and sexual dysfunction, stuff like that. And that's the reason why TURPs are not the most favored procedure for this. It's still one of the most common procedures for it, but it's also not very favored. When men hear about the risks of this procedure, they tend to say, let me think about it. And then they suffer through their symptoms over the years. So because of these problems, actually, let me go through this slide real quick. We talked about TURP. We said it's removing prostate tissue via the urethra is the gold standard. It's really the gold standard because it's been around for so long. Long lasting results with low retreatment rates. However, it's also a deal for patients with large prostates. However, you're going to have a catheter for a couple of days. The catheter meaning a Foley through the penis to drain that bladder for a couple of days. You may need a hospital stay. And also you have the risk factors like I just talked about: incontinence, retrograde ejaculations are potential risks. And because of this, not researchers and clinicians came up with other strategies that are surgical strategies to minimize the side effects of TERP and to make it more or less invasive. And here are the alternatives: Resume, aquablation, HOLEP, green light, and UroLift. Now, Resume is basically using steam. Instead of carving out the prostate tissue, you go into the penis and you use steam to kind of carve it out. Aquablation is using a water jet. HOLEP and green light are laser-based therapies. And UroLift is interesting. It's a procedure where you kind of use implants to clamp the portions of the prostate that are impinging on the urethra. The problem is that all surgical procedures are done through the penis. So you're going transurethral to do these procedures. And so obviously the side effects that come with that are also prevalent in some of these alternatives. Prostate artery embolization is the only non-surgical alternative for the treatment of BPH. It's the only one. It's literally the only one. You make an incision through a tiny pinhole. You make a tiny pinhole incision, so the incision is really, really tiny. No big incisions. You don't have to go through the penis. The method is you go in and you shut down the blood flow to the prostate, which causes a shrinkage in the prostate. The recovery is downtime is only like a day or two. No need for a catheter after the procedure, and the side effects are low. Well, how low? Well, don't believe me. Go online and actually, type in this, or you can put it in some kind of, AI system or whatnot, or just look around. You're going to see charts. And these charts basically show you relative risks of all the procedures in one slide. Okay. I know it's a busy slide, so work with me. I'm going to clean it up for you. Okay. So the first thing is we don't want sexual side effects, correct? Right. So remember, this is PAE, and I'm comparing it to all these treatments we talked about. Okay. Now, the first thing we don't want is sexual side effects. So let's eliminate anything that is high. Okay. So that's gone. Okay. Now we have to eliminate the moderates, right? Because we don't want a moderate risk. No one wants that. So we're going to eliminate those. Okay. So now we're left with low, low, very low, right? So now we're going to go to urinary retention, because we don't want urinary retention. We don't want to retain our urine after this procedure. We don't want anything that bad. So we're going to remove the moderates, right? So moderate and moderate. Okay, so now we're left with two procedures, PAE and UroLift. Those are the procedures that give you the least risk of any adverse events. Okay. And when some of these things, when I see very, very low, very low, very low, it's almost nothing. I mean, there's really very, very small bleeding risk. There's almost no erectile dysfunction risk. So these risks, they say very low because, you have to say very low. You can't say it's zero, right? So now we're going to compare UroLift to PAE, because we've already established that those are the two procedures that have the least risk, right? So let's compare them. Are they equivalent? What's their effectiveness? Okay, so you can see that UroLift is actually very good for mild to moderate symptoms, but if you start to have really moderate to severe symptoms, you need a prostate artery embolization. UroLift is not going to give you that. The prostate artery embolization is more durable. Okay, it lasts longer. Also, if you have a larger prostate, a lot of patients have really large prostates. PAE is a lot better. In fact, it's an easier procedure to do. The larger prostates you have, the easier the procedure is to do. UroLift are better for smaller prostates. Now, obviously, depending on where you live and your access, you may have just urologist. It may not have an interventional radiologist or someone as skilled as me, because it's not enough to just have an interventional radiologist in your area. You have to have an interventional radiologist that is experienced in doing prostate artery embolization. So that's why we get calls around the country from people that visit us to get this procedure, because they don't have the availability of an interventional radiologist. Whereas urologists, they're trained to do surgery. So all these procedures are pretty commonplace. So you would have to really search to find someone that can help you if you wanted a PAE. So if you compare a urolift to a PAE, in general, a PAE is probably better, and it's also just as safe as a urolift. So, does PAE work? I mean, that's a pretty simple question. Obviously, me talking about it and saying I do it and all this stuff, I mean, I know it works, but let's do it. Let's play a little game. So, does anyone know what this is? Okay, this is Chat GPT. Okay, not the chat on the screen, but Chat GPT. So Chat GPT, I love Chat GPT. It simplified my life. My life is hectic. I have a lot of things I'm doing. I have kids. I have my work kids who are my patients. So ChatGPT kind of gives me information quickly. Obviously, take it with a grain of salt. But I typed into ChatGPT, does PAE work for BPH? And I said keep it short, because ChatGPT can get crazy. It starts giving you like long manuscripts of a simple question. And so I said, let's keep it simple. So let's see what it says. So it says, I'm sorry, it's kind of small. It might not be projecting well, but it says, yes, PAE can be effective for treating benign prostate hyperplasia, reducing symptoms by shrinking the prostate and improving urinary flow. So look, this is not a secret. This thing works. This is not some kind of experimental tool or procedure to treat you. It's a well-established procedure, even though it's a new procedure. So sorry. So I also decided to ask another question. Give me some PAE data on BPH treatment. Keep it short. So I want to get a little bit more information. And I clicked on that, and it gives us some data. So let's read what it says. So it says it's effective in reducing the prostate volume. It says significant improvement in IPSS scores. This is a scoring system that we use to grade people's symptoms before treatment, and it shows that it can drop it significantly, at least 50% in many studies. It's minimally invasive. There's 1 to 2% chance of complications. It's very low. It says symptom relief maintained in 80 to 90% of patients, even up into 5 years. So this is definitely showing you that even ChatGPT believes in me. So don't believe me, believe ChatGPT, guys. So a little bit about the history of PAE. A lot of times when we find procedures and stuff like that and see if it works, a lot of times it's by mistake. And we have been embolizing the prostate artery for a long time. It didn't just start like yesterday. When people have like a TERP and they can't stop the bleeding, what do you think we do? We have to embolize it, right? Or if someone had an aquablation and they were bleeding, what do we have to do? We have to embolize it. We shut down the blood flow so it can stop bleeding. And what they found, this is back in the 80s, is that when you did a prostate artery embolization, not only did it stop the bleeding, it also improved the urinary symptoms that the patient had. So they were like, that's interesting. So in 2000, Carnevale, the renowned and famous Carnevale, did the first PAE procedure in Brazil, and it worked. And so since then, they had several studies in 2010s. This is just, in 2010 is about 14 years ago. They did a lot of studies, and they validated that PAE does work, and the procedure could rival the symptom improvement that you get with TERP. In 2017, the FDA approved embolic agents for PAE. So this is about 8 years ago. You have the FDA approval. So this is not, it's a new procedure, but it's a procedure that we've been working on for so long. And that's why we know we're very confident that it can help patients. And here is the FDA approval document. You can actually Google this, look this up yourself. So this is a 3D animation that I have. It's on my YouTube channel, and I wanted to share it with you guys in case you guys haven't seen it.
Prostate Artery Embolization, or PAE, is a non-surgical treatment for benign prostate.
Okay, so we're not going to do the voice. I'm going to talk through it. Obviously, we talked about the bladder, and that's the prostate. And you can see kind of that urine coming down very nicely, and it ends up coming out the penis. Well, when the prostate grows, it compresses on that bladder, and now you have a hard time getting the urine out. So how do you do the procedure? You can do it through the groin or the wrist. There's no difference. It works the same. And then we go all the way down, and then we find out the artery, the prostate artery. Then when we find that artery, we can embolize it. We use tiny little particles smaller than a grain of sand. And that shuts down the blood flow. Prostate shrinks, and then now you can go back to where you were before the procedure, or before you have BPH. So how do I do a prostate artery embolization procedure? So here's a video I made for you guys. So right there, I'm getting access with a needle. Tiny little needle. I pass a wire in, and now I have access to that artery. Small, tiny little pinhole incision. And now my sheath goes in. The sheath is a device that allows me to keep going back into that artery. It just saves my spot in the artery so I don't have to keep poking at the artery. Flush the sheath. And then I put a tiny little catheter the size of a strand of spaghetti into the blood vessel. I navigate my way through, up and down, just like the 3D image I showed you, or the 3D video I showed you. Okay, I'm gonna pause it right here for a second. Let me see, okay. Now, here is why you can't just go to any random person for this procedure. This is why it's important to know that your provider has the expertise. That's the superior gluteal vessel, inferior gluteal. These are the vessels that go to your behind, to your butt. And that's the artery that goes to your penis right here. And so you want to make sure that your provider knows the anatomy, because if they go to the wrong blood vessel, it can be a problem. This artery right here, see this tiny little thing? That is the prostatic artery. And see how tiny it is? You literally have to take a tiny little tube, even smaller than the one I just showed you, and find that tiny little artery. And that's why you can't just go to any Joe Schmo that just says, oh, I just do it. You have to go to someone that does this constantly. I do this. These are one of the few procedures that I do on a daily basis. And so that's why I have the skill set to do this. So see this tiny little artery, we're gonna get into it right now. You can see that's my catheter right there in that tiny little artery. I'm injecting it with some dye, and that's how I'm able to see it. So now I'm putting together the mixture that I'm gonna use to embolize. Now I'm on the other side. You can see that's the bladder right there filled with dye, because obviously we're using dye in this study. And the prostate, you can make out kind of like the outline of the prostate right there. And that's me in this tiny little vessel injecting it. And you can see it's very, very small. So you have to have the skill set to do this. And that's it. And when we're done, I put a little radio band over the access site. Just very, and that's it. We keep that radio band for 30 minutes and we take it down, and that's the whole thing. You leave with a Band-Aid. No big incision, no going through the penis. So does the procedure hurt? So here is a pinhole incision, what I was telling you about. It really is a pinhole. It's not a large incision, and this is 2 weeks after the procedure. It's almost completely healed, or really completely scabbed over, so it's healed. So this is not a painful procedure at all. And also, even when you go back home, the recovery, it's usually Tylenol. Sometimes, rare cases, we might give a little bit of Percocet, but it's not a procedure that is very hurtful. This is a procedure that's well tolerated, and you can go back to work in a few days. So why urologists don't recommend PAEs? Okay, so I have a good way to answer this. And we're gonna go back to our favorite thing, ChatGPT. So we're gonna type it in, and I wanna see what ChatGPT says. Why don't urologists recommend PAEs? Okay, let's go. Let's do it. Keep it short. I gotta tell them to keep it short. So it says, number one, it's not part of their training, like surgical options like TERP, unlike surgical options like TERP. So it's limited training. Awareness gap. Many are less familiar with PAE's effectiveness and indications. So it's fair. TERF dynamics. PAE is performed by interventional radiologists, which can create referral hesitations. I didn't say this. Don't blame me. Perceived evidence, some may view PAE as having less robust or long-term data compared to traditional surgical methods, and that's fair. It just came out, but it doesn't mean it's not effective. There's numerous studies I've compared it in TERF, but I also told you we've been doing embolizations for a long time. It's just now that we have the data to support it. Okay, but that's the answer right there. I don't need to say anything else. We just need to just keep it at that. So here's a patient testimonial. I want you to bear with me. Listen to this guy's story, and maybe we can learn a little bit about how this impacted his life.
It was a lot of sleepless nights. I would have a lot of stomach pain, sitting on the toilet forever. Sometimes I would fall asleep on the toilet waiting to go. And then when I do go, it would come out so slow that it just took forever. And then when I think that I'm done, go back to bed, but I still feel like I have to go. And then I'd be up 2-3 times a night. Interrupted my sleep, so I was always tired. Always felt like I couldn't go, and the lack of confidence of being able to go. Gravity was my friend, so during the day when I'm walking around in the day, I felt okay, but when nighttime came and I knew it was bedtime, I would feel like, torture time. Go to bed, I know I'm gonna be up all night trying to go to the bathroom. It was just disturbing to go to sleep every night. My wife heard about Mint. I never heard of Mint, and then she told me the location. There's a location right there in Fairview Heights, so I drove past it. And I was a little nervous about going in. I didn't know what the procedure would be, but I finally got the courage to go in and get the consultation, and then it went from there. I wasn't looking forward to any kind of surgery. My father has had surgery for the same reason. He told me all the stuff that he went through, and during previous examinations, all leading up to the surgery, I kind of experienced a lot of the stuff that he told me that I would go through for the surgery. And some of it was painful, some of it was very uncomfortable, and a lot of examinations. And also, I came in and I got the consultation, and I was not looking forward to the surgery that my father received. And they explained to me that it's very invasive, in and out. I'm not going to be in the hospital over a long period of time, so it was an easy decision. For one, I can stand when I go to the bathroom. That's a big change right there. I don't have to sit. Second is sleep has returned. I'm able to get through the whole night and sleep. I can even, if I have to hold it, I can hold it. I don't have to run to the bathroom when it's time to go. And when I go, I empty in the first try. I feel relieved as soon as I go. I had no complaints. Everything to me went smoothly. I wasn't aware that there was going to be 2 procedures, but They told me 2 different ways that it's done.
So as far as him with the two procedures, it's not. I guess it doesn't happen with everybody. Sometimes your prostate artery has different angulation or whatnot, and so sometimes you would have to y- come out, do it from the wrist, and then come back and do it from the groin. But again, this is a procedure. It's not like major surgery, so it's in and out. It's like a 30-minute procedure on each side, so it's well tolerated. But it's not all the time, and sometimes you can get both in the same session. It just so happens for him, he had 2 sessions.
And I experienced both separate procedures, and both ways was fine. The recovery wasn't very difficult. 2, 3 days I was down maybe, and then by the 5th day I'm up on my feet and back to work. Everybody was great. Made me feel comfortable. I never had surgery before, so I was really nervous, but they made me feel like, it's all gonna be nice and easy. It was, comfortable setting, relaxing, even up to the point where I went in for the procedure. The doctor was excellent. He explained everything to me. I was clear on what was gonna happen, and when it was over, they comforted me until I was ready to go home. And it was good. They gave me pretty much a lot of information for the recovery, so I knew what to expect.
So I'm gonna stop it there, but obviously my patient testimonials are on the YouTube channel, as I listed down below. You can see some of them. But yes, I mean this is a procedure that it has changed a lot of lives, and you don't have to have major surgery for this thing. Your prostate is not cancer. It doesn't have to be removed. It doesn't have to be resected. You can just embolize or shrink it and get back to your life. So does insurance cover the costs? The costs. And so this is an important question. Medicare covers it. Medicare Advantage plan. So all those you can have like United Healthcare, Medicare Advantage. Those cover it. Some private payers do. The best thing is to call us and give us your insurance, and then sometimes we have to do a pre-authorization to see if it really does cover it. If it doesn't cover it, at the very least, we can always courtesy you the consultation. Um, we also have plans for people who want to pay cash. So if you want to pay cash, we have plans. Just call our office. We have like payment plans or whatnot, so we can help guide you depending on what your situation is. How long does a procedure take? Usually about 45 minutes. So it's not very long procedure. How much downtime after prostate artery embolization? So as you can see with him, it was 2 to 3 days. We usually average about 1 to 3 days of downtime. It's honestly not much downtime at all. It's also patient specific. The procedure itself does not hurt. There's no big incision, so usually you leave with a Band-Aid. When you get back home, sometimes you have a dull little pain, kind of in the pelvic area, but we typically just recommend Tylenol or ibuprofen. In some cases, we may have to give a little bit of Percocet, or narcotics, but nothing crazy. No big hospitals. There's no hospital stay with this procedure whatsoever. You go home the same day. So we are at the end of the webinar. I appreciate you guys joining us today. This was amazing. We're gonna do multiple of these, so just follow us or whatnot. Check in with us. I'm gonna have multiple of these because I love to interact with y'all. And this is just as a bonus of watching this. You have a free virtual screening. It's about 15 minutes. It's not a consultation. If you're saying, I just want to talk to the doctor or one of my providers and just see if I'm a candidate, we would offer you a free virtual screening. Again, this is not an actual consultation, so we'll make it free. But if you want to just step into it and get a consultation, sure, give us a call. We do our consultations both virtually and in person. We do a lot of virtuals for people that are out of state. Here's our office contact information, so take a picture of it so you can have it saved, and our social media handles. Follow us. We're doing some cool stuff on YouTube and Instagram, and so you can really stalk us and see what we're about. So now I'm gonna answer a few questions. I know we kind of went a little bit over with time. I like to keep these things short so I don't bore you guys out, but I do have a few questions that I'm gonna answer from the audience. One of them is, how do I know if I'm a candidate? Um, there's no way to really know. Honestly, if you have an enlarged prostates, you're probably a candidate. There's very few prostates that we cannot treat. So don't rule yourself out. Give us a call. Typically, we'll do some workup. We ask you some questions. We'll see what your labs look like. And then we rule out cancer. We just want to rule out cancer, make sure it's nothing bad. But yes, most people are candidates for this procedure. What's the recovery time for prostate artery embolization? We talked about that already. So just after this, we're gonna send you a link to rewatch this video, so you can get all the answers back from there. So, if I come from out of state, how long do I have to stay in St. Louis for recovery? So typically, it kind of depends on how far you came from. I had a patient that came as far as from Alaska, and I had to keep him there for 5 days. But most people, if I went through the wrist and I treated both of them, honestly speaking, you could probably leave in maybe 2 days, so have a 2-night stay. It just depends. I do want to make a comment. We have some help for people who are in areas that where they don't have a person like me that can treat them. We can help you with your needs and navigating your way to St. Louis, help you with some of your travel plans or whatnot. So just give us a call. Also, if you're a person with economic needs, we can kind of help bridge that gap for you. Maybe you have insurance, but you have a hard time, coming down, or you have a hard time navigating flights or whatnot. Just give us a call. We could definitely help you guys. Okay. I don't have insurance. How do I pay for this? So yes, insurance does cover it. That'll be ideal if you're over the age of 65. You could use Medicare. Medicare covers this. However, we do have payment plans for people who their insurance doesn't cover it. Just let us know. It can be. We can guide you and navigate you through that. The payment plans, I believe, it's less than a car payment. Actually, I know that for sure. It's less than a car payment. So if you give us a call, we can help you navigate some of these issues. Okay. Hey guys, I gotta go. I'm gonna wrap it up for today. If you have any additional questions, leave it in the chat. I will review them, and if you leave your information, I can definitely get in contact back with you, or you can email us at my email, which we put it right there on the screen, or you can just give us a call, and we can help you navigate through all of this. Okay. It was a pleasure, and everyone, take it easy and be safe out there.